colleague and friend, Dr. Dana Hawkinson, Hawkeye, Dr. Hawk, Dr. Dana, as apparently his family calls him. And
Dana's fine.
Dana's fine. I don't know. And then we have a special guest this morning, Sonia Bartolome. Sonia is a pulmonary critical care physician at the University of Texas Southwestern in Dallas, and one of the top academic medical centers in the United States, where she is also the associate director of quality and really heads up their COVID response team. We thought it'd be fascinating to have a good conversation with Sonia, who used to be here at KU. She was a KU Jayhawk grad. I think she would still consider herself a Jayhawk through and through. I see the Jayhawk right behind her head on the video, which is perfect. She did a residency in pulmonary critical care training here, went into pulmonary hypertension, and eventually found her way to Dallas, Texas, where she's done great work. And it is a pleasure to have on there. Sonia is also a good fly fisher woman. Been fly fishing with she and her husband a few times, and they do a great job. So it'll be fun to have her on the program this morning and hear a lot about what's going on in Dallas, Texas. But before we turn to you to kind of give us an update, Sonia, Dana, how are we doing today here at KU?
We continue to not do good.
I know, not do good. I don't know about that. Not do good.
I think that's lexicon now. We've talked about this last week, how our numbers have gone up, 18 or 19 to 22 to 25. We're up to 35 today. Luckily, only 12 of those in the ICU and only 4 of those patients on the vent. So that is a good thing. But overall, our hospital numbers continue to increase as we see increasing cases throughout the state, throughout the city. And we know that our other healthcare partners are also having increased hospitalization numbers too.
We do. Throughout Kansas City, I call it the Big Six. It's not necessarily the size of the hospital, but there are 6 hospitals that are on a CMO, Chief Medical Officer, phone call 1 or 2 times a week with us. And we kind of went around the horn yesterday to see how everybody was doing, and everybody's numbers are rising. Yeah. It's not unique to us, but all the major hospitals in Kansas City, St. Luke's and HCA, Liberty, North Kansas City, Shawnee Mission, Advent, Olathe, all are rising and rising fairly rapidly. And I think what we're seeing on our curves when you look at them is that the lines are straight up, and that's a concern, right? Because we'd say before, when we said let's shelter in place, well, we'll bend the curve. We'd started to bend the curve. Right now, there's not a lot of bending going on.
Right.
The number of new cases in Kansas City and in Wyandotte County and in Johnson County are really rising rapidly. And if you look at the states that have some of the highest rates per capita right now, Kansas is right. The highest new cases per capita, Kansas is right at the top of that list. And Missouri is not far behind that. So until we see that curve start to bend, we're going to know that it takes about 2 weeks to get sick enough to be in the hospital. So we're going to watch those numbers rise, and I would not be surprised to see us to get to 60 or 70 patients over the next several weeks.
Absolutely, and we've anticipated that. If there is a silver lining, we know that our discharges have been more. The unfortunate thing is we're getting more admissions. So our hospital stays are shorter. Again, they're not necessarily critically ill, needing ventilators. They are getting out of the hospital, but that can still overwhelm our hospital bed capacity. That can still overwhelm our PPE capacity. So, and we know how to protect ourselves.
We
know that physical and social distancing works, along with mask use and hand hygiene. You understand, and we understand, like if I wanted to start smoking, I can't go into a restaurant or a store and start smoking because it's a public health issue. This is the same exact thing. It's a public health issue, and wearing masks and being distanced protects other people.
Yeah, I think that's the key. What you said it great, and I love the smoking example as a lung doc.
Yeah.
We do things every day to help protect ourselves and help protect the rest of our society, and one of it is to not smoke in an indoor place like that. And so wearing a mask is really not that big of an ask because it's not a forever ask.
Right.
It is a temporary ask that we, in order to help keep people safe. So Sonia, how are things going in Dallas, Texas?
I think the story has been very similar here as what you're seeing. We're just a little bit ahead of you on that curve. Our cases really started to increase several weeks ago. After shelter in place, we had a very early shelter in place because very early in the pandemic, our numbers were doubling every 3 or 4 days, and we saw a rise in our cases pretty quickly. And shelter in place was put in early because of that and was very successful. Our percentage of testing rate, positivity went down, our doubling rate went up. from 2 to 3 days, all the way out to 30 days approximately at that point. But then as summer came and holidays came and people got out and about more, our cases have really increased. We have a campus with a couple sister hospitals that our faculty work at. Parkland is the county hospital across the street, and on the other side of the street is our university hospital. We currently have 50 inpatients in our university hospital, 20 of whom are on the ventilator, and our county hospital has 163 inpatients with 40 on the ventilator. So it is stressing our resources, but we've planned for that and are able to take care of all those patients.
As far as masking and the city going, are the bars still open? Are people trying to bend the curve back again? Because we know how successful bending the curve was. It clearly worked. We went from about 40 patients to 9, and now we're back up. But talk to us a little bit about where Texas is on that part of the spectrum now, and where Dallas is.
So Dallas opened up relatively quickly because our caseload had dropped quite a bit out of after shelter in place. And since that time, our case counts have gone up. I think the message about mask wearing certainly early on was a little less clear, and so that wasn't occurring as widespread as I see it now. Bars were fully open, and restaurants hit about 75% capacity, and then we had to back those plans back down. So bars are now closed because it turned out those bars and young people congregating in small places, obviously difficult to drink with a mask on, those were areas where outbreaks started, and so the bars were closed back down. Restaurants are still open about at 50%, and yesterday in Dallas it was decided to postpone the start of schools in person until September 7. They can do online classes before that. So we were open, we've backed that back off a little bit as case counts rose.
Has it been long enough to tell if the curve's beginning to bend?
That's hard to tell. As you know, you see every action about 2 weeks after it happens. And so what we're seeing right now is a leveling off of cases. And so I am hopeful that we're starting to see that bend back down rather than continuing to rise. Our inpatient census has stayed between 50 and 60 for the last couple of weeks or so. And so we're happy about that leveling off and hope that these increased measures will make it continue to fall.
And you all in Dallas, I believe there was an order by the governor that said cancel elective cases. Is that still in place?
It is not. That was lifted when our case counts decreased. We have a new order that does shut down elective cases depending on your hospital capacity. So if you're still able to care for more patients, take more COVID patients that you need to, you can maintain elective cases, which is currently where we are.
And I think we've heard that to be being part of our story as well, that we may come up to that. What we found is that our hospital's full with all those people who hadn't gotten care before. Our case mix index, which is a measure of intensity and how acutely ill someone is really high, and much higher than it normally is in the summer when it tends to go down a little bit. The census tends to be down a little bit when the surgeons take vacations, et cetera. Well, nobody's taking a lot of vacations because there's not a lot of places to go. And the CMI is really high. Is that similar to what you're seeing?
Saw that. Patients were avoiding care, I think, during the shutdown, who really needed to come to the hospital because people were afraid to be out and about. And although we don't want large groups out and about, we do encourage people to continue their normal medical care. Certainly, this stresses the system. We've had to get a little creative to accommodate patients. We've moved some of our service lines out of the main hospital into a specialty hospital. We're doing some procedures on other campuses, and we've actually turned a unit in our hospital that used to not be an intensive care unit into an intensive care unit. And by doing that, are able to still take care of everyone with their normal medical problems or perhaps things that have been not treated as aggressively over the last few months while still taking on the new COVID cases.
Yeah, those sounds like familiar refrains. I think we've certainly experienced the same thing. And we built a new emergency room bay for all the COVID patients over a weekend.
Yes.
You know, it was one of those, it was like a barn raising. And I think that those are the things we're all doing to try to adapt to the rise in cases. Well, any other important thoughts you want to give us before we turn to our questions? And we're going to give you some of those questions too. So anything else from your standpoint, Sonia, thus far?
I think this show is great. I watch you guys all the time, so I appreciate being on it. I would just reiterate what you all say all the time. You know, washing hands, wearing a mask, staying away from large groups of people is just our way of taking care of each other. And it's something that won't last forever, but that's how we make this stop.
This morning we do it by Zoom or here in the media room, and I didn't sing it, which is to the benefit of everybody, but the long and winding road, the Beatles song, the long and winding road, that's what we're on. We're on a long and winding road, and it's going to have ups and turns and ups and downs, and we're just going to have to be on it together. And if as a society we can take care of each other, we'll be safe on that road. But in the meantime, when we're not, we don't wear a mask in public, we don't distance, we don't wash our hands, we don't do the things we know we have to do to keep folks safe, and instead we turn them into political things, then that road becomes more long, more winding, and it takes more lives. And what we want to do is travel it safely together, because there is hope down the road, and it's not that far.
And I think Sonia makes a good point about the individual hospital, about capacity, and can you still do things? And we're learning more and more about this disease. Of course, there are the general things that everybody should be doing, the distancing, the masking, the hand hygiene. But as we're talking about getting schools back or getting church services back or religious services, you know, all of the administrators, all of the leaders in those things really need to examine their own place, because as we're learning, you know, all of the communities, all the cities are different, the school districts are different, the schools. Certainly our city, Kansas City area is much different than other cities. So as we are looking at this, we need to understand the infection dynamics of our local community.
Yeah, it's a big. So Jill, I bet there's some questions out there.
Yep, I do. Does media have any?
All right, media, any questions this morning? Not hearing any.
All right, Lindsay has a question. She read a report out of Texas where a doctor said they were using a combination of antibiotics, zinc, and budesonide.
Budesonide. Inhaled budesonide. Yeah, I read the same thing. Okay, Sonia, out of Texas, that's got to go to you. I mean, let's go here. What are you doing with the inhaled budesonide out of Texas?
So I would say that was a physician who was talking about his personal case experience, which I think is interesting, but that hasn't been done in a rigorous academic fashion. We do use steroids for our patients who have severe COVID lung disease, and there are good studies on that. As far as recommending inhaled budesonide for everyone, there are side effects to that, and so we're not currently doing that at that time. But we have over 20 ongoing clinical trials into COVID, and I think we're going to find new treatments and better ways of taking care of people with our traditional scientific approaches. But yes, interesting, and we're keeping an eye on that.
Yeah, I know that was the, I think, actually nebulized budesonide, and yeah, it was. You and I both know that's okay, you're probably too young. That's a very old treatment that we used to use, and not something that I think would be as applicable to this disease. And one of the things we have to remember, we have to be careful with inhaled therapies with COVID, because there's already lung injury, and if you have an unintended consequence of that therapy and it's more a lung injury, we may not have helped them. And so we have to be thoughtful about it, and just kind of going out and shotgun and stuff, I don't know that that's the best approach in this. There's always this sense that we're going to go do something. Yeah. And sometimes doing something isn't the right thing, because the body's trying to do things itself. Don't interfere with that part unless it's part of the body doing too much inflammation, beginning to short circuit a little bit. Then there were things we do to help with that, like anticoagulation and steroids, but they're oral steroids, not inhaled steroids. I suspect that's going to turn out to be a lot better route.
Yes.
Tricia had a child who had Kawasaki disease in 2016. Her child is fully recovered, but she wants to know, does it put her at greater risk of juvenile inflammatory syndrome if she contracts COVID?
COVID-19. You know what? That is going to be even a special question on Monday, because we have the director of infectious disease and the CMO from Children's Mercy on the program with us. So flash forward, you might want to think about that on Monday. We'll try and answer that as well. I don't know. I'm going to look to my COVID expert. Sonia, any thoughts about that?
I would say that data is a little scarce to tell. I'm not a pediatrician, so I probably shouldn't comment on that scientifically, but we haven't seen that in case reports so far and are keeping track of those pediatric cases closely.
Yeah, I would agree. I don't know that a previous history of traditional Kawasaki disease would put you at risk after COVID infection for the multi-inflammatory syndrome.
I think it's safe to say what folks are doing are merging Kawasaki disease and this inflammatory thing post-COVID and saying, oh, they're the same thing and I'm at risk because I've had it once. Actually, I don't think they are the same thing. I think they have some similar features, but because they aren't really the exact same thing, I'm not sure that because you did this, you're going to do this. And we'll talk more about it on Monday, but I would be surprised that relationship exists.
Donnie, Marcia, and Nancy all have questions that are in the same family of questions. They want to know, what is the capacity for COVID? What is the highest number of cases we've had here at the hospital? But they also want to know, they have a friend who's an elderly person, and she came down with COVID but hasn't gone anywhere. And they just want to know, what is causing this surge? Is it people not wearing their masks?
Yeah. So, I think we're going to borrow from Sonia's experience and what we know to be true. When people congregate in settings together, especially inside, and we blame bars but mostly because alcohol tends to lower inhibitions and people get closer together. But it can be a church, it can be a sporting goods store, it can be anywhere where there are a lot of people congregating together inside without masks, especially. But you can even overwhelm masks if you get a lot of folks close together. That's really the source, and we saw it happen as soon as society began to reopen. The number of COVID cases began to rise. And it's pretty simple. When people are together, and again, especially when they're inside, that air cloud you breathe gets run into other folks' air cloud, or you start intersecting, and as you do that, you inhale other people's particles, if you will, and that's when you start spreading the disease. And so that's our struggle, and that's why we see the rapid rise in cases, Dana.
Yeah, absolutely. It's the congregation. And the virus doesn't care if it's a bar or a restaurant, doesn't care if it's a service like a funeral or a wedding or a birthday party. It's just the people congregating together, not being physically distanced and not having the mask on for both parties. Both of the people interacting with each other, and that's the main issue.
Sonia, additional thoughts, because I know you all have seen that in Texas, and then they closed the bars and cut back on restaurants.
And we've also seen that people think that being outdoors is safe, which it's safer, and we do want people to go outdoors. But if you're outdoors in a group of 100 people without masks, that does not remain a safe thing to do. So just as you said, limiting gatherings, but still finding creative ways to have fun. It's summer. My young adults in my house are tired of being inside, so we have to find things with small groups of people to replace that social interaction and fun that they're used to having. So I would agree, just staying away from large groups, finding creative ways to interact with others.
And don't you think fly fishing is a great way to do that?
It is very social.
Good. Going out into Mother Nature.
Our capacity and our numbers.
Yeah, so we're seeing the rise, and here's the story. And like what Sonia has said this morning, you know what? You build the capacity, and you reconfigure yourself in order to handle the patients that you're being asked to take care of. I don't think Kansas City is at capacity. I'm not worried about that today. But what we know is that we had a lot of folks who delayed care. They're now in care. The census throughout Kansas City for routine hospitalizations is high because there are still sick folks. If I go and look at the 700 people in beds this morning that don't have COVID disease here at KU, you know what, they need to be in hospital beds. It's not like they're taking up a bed and having a party. And so as a result, you have to take care of COVID patients on top of the people who already need care. And that's the challenge to all of us. You heard Dr. Bartolome talk a lot about what they had to do in Texas, and that's a story that all of us are facing and trying to reconfigure our hospitals to do that. I believe we have the ability to do it, but if the curve continues to rise and we get into a really severe situation, then we could run out of beds. We're not there right now. But can I tell you what's going to happen in a month from now? I can tell you if people socially distance and wear a mask, we'll be fine. I can tell you if you don't and you congregate together and we don't do something with a rapid rise in the curve, we're going to be challenged. And it's all about social behavior. If folks will help us, we can do this, but we're going to do it together. I think that's been the experience in Dallas, Texas, Dr. Bartolome.
Absolutely. I also talk to my patients about masking because people think it's not effective because of many of the things you see on the internet. And, you know, I've had many instances now since we have such a high community spread here where I've gone in to see a patient in my clinic who had no symptoms of COVID, but the next day developed them and therefore was a pretty large exposure for me. We're touching, we're in a very small space together, but we were both masked, regular masks, not N95s. And even with multiple of those close interactions, I have not so far picked up that bug. And so if it works for us in this small space, it'll work for you too out in the community.
It really does. And that Internet Research Journal, where things are peer reviewed by people who think exactly as you do, is such a great source of information. Of course it's not. And so what we have to do is look at that and remember that when people who believe exactly as you do look at things that you've written and agree with it, that doesn't make it true. One of the things about medical journals and academic journals in general is that when you send publications out to be reviewed, they're often reviewed by people who don't agree with you, and they try to punch holes in everything you said, and then you're given a chance to defend it and try to make sure your research and your arguments are sound before it ever can get published. Most articles are never published because they're not sound enough. So be careful with what you read on the internet, especially when it's been reviewed by people who think like you. That's an important difference.
Jennifer wants to know, why don't we put used one-time masks in infectious waste bins?
Okay, why don't we put those in infectious waste bins, Dana? We can sometimes just throw them in the trash.
Yeah, absolutely. You know, again, for the most part, the masks are mostly going to be worn by people who don't have any disease. But we know that you can carry the disease and be infectious to other people even if you don't know you have it. Really, the bioburden, the amount of virus or particles or droplets that the mask collects, is really not going to be a biohazard. It's not really going to cause other people disease when it goes into the trash. It's a little bit different than, say, and I think she's probably alluding to other like bloodborne things where we do have bloodborne containers, specific containers, but really the amount of virus and the ability of that virus to jump off the mask is going to be nil. So really the danger to other people, if you throw it in a trash can at the park or at the grocery store, please do not leave it on the street. We are seeing a lot of PPE, gloves, and masks on the street, but throwing it in a normal trash can is really not going to pose any harm to anybody else. And again, as you get further out in time, hours to days, really the viral burden is going to really decrease. You won't, it'll degrade, so it's not really going to be a danger to any of the public.
And when we throw a mask away into the routine trash here in the hospital, our trash is not your trash. And what I mean by that is that we handle it a lot differently. Mm-hmm. Medical waste is not disposed of by Deaf and Baugh and their big dump. And so we have to do special things with it, and so it'll be different. But to Dana's point, when you see it out in the public, I think that's right. You know, those masks don't really contain the virus that long on that surface that's going to be spreadable to others. And again, as we go further into this COVID journey, we realize that while surfaces are important, the real thing is what you're breathing out.
Yes.
Janelle says, with rates rising, I hear people's reply with, but the death rate is lower.
Oh, the death rate is lower. Oh, ouch. Okay. Sonia, has the death rate remained lower, or are there more deaths overall now?
Well, we see that around the world and certainly in the United States in relation to whether you've overwhelmed your health system capacity to take the patients or not. And that is why all these measures are important. If we can avoid overwhelming the system, then we have the people and equipment to take care of folks, and outcomes do tend to be better. Also, younger people were getting it here. A couple weeks ago, about 45% of our inpatients were under the age of 50. That age is moving back up again. When younger people were getting it, they do tend to get less ill. We know that your severity of illness and likelihood of death will increase with each decade of life. And so we are seeing that move back now. The other thing you see is our average length of time on a ventilator is approximately 21 days. And so even our patients who do not make it, unfortunately, are in the hospital for a very long time. So there is some lag both in disease progression and reporting of that in the death numbers. So I am still hopeful, because younger people were getting it, that death rate really stays a little bit lower. But I think it's going to take a few weeks to know that for sure.
I think that's the story here as well, right?
Yeah.
We saw a younger population, but the younger population gets sick, and then it spreads. And it doesn't just spread to a younger population. It starts spreading back to parents and then back to grandparents.
Yeah.
And so whereas we saw a nursing home mortality largely initially, that has calmed down. But now we also know that the rates in some of our nursing homes are beginning to go back up again, and we're seeing the age distribution, which had gone down, starting to generally go back up, and it's because we're all sharing the virus. And I think it's important to know that even though we may spread it, you said earlier, in a bar, it doesn't mean that virus only wants a rye Manhattan.
Right.
What really happens is that you take it back home, and then you give it to your parents, and then the parents give it to the grandparents, and then pretty soon we have a lot of people who are on ventilators again. And I think that's all of our fears about where we're headed.
And I think it's too simple just to think about hospitalizations and death rate. The problem is this virus infects everybody. It infects young people. Even if you're not going into the hospital, there are young people who have to stay home and who don't feel good for the next 2 or 3 months. There are people who can't go to work. So it's an overwhelming of our other essential services, the people that are delivering our food to our stores and our restaurants. We saw what happened when just 5% of the pork industry had to shut down. We saw what that happened to our economy. Meat prices climbed. There was lack of food. And so it's really just a general sense of all of these supply chains. What if it's our first responders? What if 50 or 60 or 70% of our fire people aren't able to do that, of our firefighters or our ambulance drivers or our police? So it is far reaching. It's not as simple as, oh, well, there aren't many hospitalizations or deaths. It's all of our supply chain in things that everybody need every day in the United States.
All right, Jean's got a son who, along that line, it's a tough question, but Jean has a son who was exposed to a coworker a week ago Friday. On Tuesday, the coworker goes home, fatigue, high fever. Now he's been told by the coworker that I was positive with COVID. Not hearing anything from his employer. He doesn't have any symptoms. Does he go to work? He doesn't also have any PTO for quarantine.
Yeah, those are hard questions,
That's a
Dana.
hard question. So the first thing I would do is definitely try and get an answer from your employer. The second thing to do is contact your local health department. You know, it sounds like it was a Friday where the exposure was, and then Tuesday the person started having symptoms. Whether this is right or not, the CDC has decreased their contact tracing. I think it was originally at 10 days from when somebody got symptoms to when you have to look back and say, was I exposed to that person? Now they've decreased it to 2 days. So if you're outside of that 2-day window, technically you wouldn't be in the contact tracing. But again, we know that you can be infectious, certainly most infectious 1 to 2 days prior to symptoms to 1 to 2 days after symptoms. But you can be infectious even 3, 4, 5 days because we can detect it on tests. So that's a very difficult question to ask. You have to understand what exactly was your exposure. Were you in close contact, 6 feet or less? Was it a prolonged time, 10 minutes or more? Was anybody doing masking? So really try and get an answer from your employer. If not, your county health department. If not, go to the CDC and try to look up their recommendations for contact tracing.
Yeah, it's tough out there because those are great questions, and unfortunately, those are questions throughout society because we don't have a lot of the precautions, a lot of things that had been in place, government programs, et cetera, to help with unemployment, et cetera, have ended. So,
and if this conscientious person is trying to do the right thing and not spread it to other people, it makes it more difficult. So.
Yeah. Joyce wants to know, with the change in reporting of data from the CDC to HHS, how is that going to impact tracking in Kansas and Missouri?
That's a great question. Sonia, let's first of all, tell me your thoughts about that, because I know that's something that will be close to your heart.
Yeah, certainly I interact with reporting a lot for our quality and safety measures. It's an unprecedented change. It's thought to be being used to help us get some resources like remdesivir by caseload. And so if that occurs, that will be a helpful change. I think we're just going to have to wait and see how that system goes. We currently still report all of our cases through the state of Texas, and that reporting structure remains intact. I'm sure you have something similar there.
Yeah, we report all things to Kansas and Missouri, but it is handicapped because our backbone of our reporting structure was the CDC structure. And so that's now been shut down. You can't use that database anymore. And so it has created hardships. And I think the thing to remember that in the world of federal government, the CDC is considered what's called an independent agency, which means it's more bipartisan. HHS is a White House group and therefore has a little bit more of a partisan flavor. And so that, I think we just have to be thoughtful about what does it mean when you leave some of the most important public health data of our time from an independent agency and give it to a more White House directed agency. It's not saying whether you're a Republican or Democrat. It's just you have to think, where do you want your data being done so that we can all look and interpret that data together in an unbiased fashion.
Yeah, and we have to remember the entity that we're talking about, the CDC, their main goal for the past 75 years has been to protect public health and give guidance. So that is much different. They have a lot of experience doing that, a lot of experience taking the data in, reporting the data, and then doing positive things with that data. So
I think we're a little concerned about it, to be honest. But because we can track the data here in Kansas and Missouri, and honestly, when we had a call from some of our local governments, and they were concerned about the change in the data reporting, and they wanted access to our CMO data because they're like, okay, well, you've got real data. Tell us about how that looks. And it's like, come on, guys, we can do better than telephone call data. We got to have real data. You can't act on that.
And Brian has a data question too, and he said, any response to my questions, and so I'm sure they're buried somewhere, but he's talking about false positive rate put out by the FDA. Do you have any idea what he might be talking about?
False positive rate.
I've been asked, I was asked like 2 or 3 times a couple days ago. I don't understand that. I actually asked Dr. Leisman in our lab, who is our lab director and has really a lot of knowledge about all of these tests, especially the tests that we're doing and have validated. And she didn't really understand and know what that meant either. So we'll take a look and see if there was an FDA. But these tests are so sensitive. They are so specific for the genomic material that I don't know about really a false positive.
It's not on the nasal swab. I don't think that's a real concern. And Sonny, have you heard anything about with nasal swabs, a false positive rate?
Was referring to, but we do see that on the antigen test rather than the PCR test. And in fact, I'm sure you're very similar, but in our patients who need surgeries or procedures, we have a certain list of tests that we will accept and some we will not. Certainly some of the home kits that people are getting have very high false positive rates. And when we tested some of the available antigen tests in our institution, we found a high false positive rate, especially in minimally symptomatic patients who aren't very sick. And so perhaps it's dependent on the type of test.
Test, but I think the nasal swab, PCR tests are pretty darn reliable.
And again, we just use the PCR test here.
Yeah.
And Jamie and some other people, I think we spoke to this yesterday, but they want to know if I've been in contact with someone who tested positive, I've been quarantining, health department is telling me don't get a test unless you have symptoms. What are your thoughts on that?
Yeah, I would agree with that. I think we are running into testing capacity issues overall. Luckily our turnaround time is still 24 hours or less here, but certainly in some of the other private labs and public health entities, their turnaround times are 3, 4, 7 days.
Yeah, 5 to 7 days is pretty common now, I think, for Quest and LabCorp and others.
And the capacity has to do with just the amount of tests, the sheer volume of people that want to get tested, but also the allocation of reagents and materials to do the test to any of these places. So we have always recommended that stay in the quarantine if you're a contact. we understand that the test that you get that day is really only good for that day. So unless you're having symptoms, just continue to stay in the quarantine and don't go get tested because of those other reasons.
Yeah, and I think that's right. And plus, an exposure is not an exposure is not an exposure. You have to kind of get that little more definition to what that exposure was like and how much time people really spent around someone who is positive. And if you're outside and you wore a mask, you say, oh, I'm around somebody who yeah, you're probably fine. If you were inside a small, smoky room with lots of folks and lots of our air clouds around each other, okay, you may not be fine, especially if you're there for a long time.
Jeanette wants to know, what is an inconclusive COVID-19 test result? She wants the doctors to explain that.
Okay, inconclusive.
Yeah, I would really, again, most of the tests that I'm going to talk about are the PCR tests because that's what we use here. We don't use the antigen, and we certainly don't use the antibody to detect acute infection. So, I would say that result probably means there was probably some interfering substance within the test itself, whether it's the reagent or how the test was prepared. At that point, we would typically just repeat the test. Again, that's going to be difficult, but that's probably what that means.
And what the lab does a remarkable quality control here, and we do it every day. And Rachel Leesman and Fred Plapp and team really spend a lot of time to make sure those results are good. But there are some times where there's something not quite right about the swab, and it comes out inconclusive, and we go back and retest.
Yep.
And we call and let folks know that. But I tell you, that doesn't happen very often, especially because I think as we've gotten so darn good at testing and swabbing that we just don't see that happen as much. Sonia, you guys seeing many inconclusive tests?
But there are many places, as you know, where a test can have problems. It's the collection of the swab itself. Did you get really far back in there? How long? We do ours for about 10 seconds. You want a good swab. Also, where you are in the course of the disease, which Dana can probably talk about certainly better than I can, but are you early? How's your viral load? That sort of thing. There are many places along the testing route where things can go awry. There's no test that's 100% and always comes out accurate, so we just repeat them, as you say.
Actually going to go to Dr. Bartolome's point, in the disease process. So luckily, Dr. Leesman can go deep dive into every test that we run and can look at it. And based on what she sees in there, is it just a super low viral load that the machine didn't pick it up after going through all the cycles of the PCR, where we can run it on different instruments because we have several different platforms and they have different sensitivities. But you can go and deep dive into that, and is it just an extremely low viral load, or was there something else wrong with the test?
Jill, probably time for one or two more questions, and I think we'll be wrapping up today.
People are kind of curious about the demographics of patients at both hospitals. They want to know, do they have underlying comorbidities? Are they, you've talked a little bit about the age is skewing younger. I think people want to know,
what's going on with that?
Yeah.
So, Sonia, how is it in Texas? Comorbid diseases, and I'm curious because one thing you mentioned you had at UT Southwestern, and you had a high number of ventilator patients, so a high percentage relative to what we're seeing. So, talk to us a little bit about what does your population look like down there?
Different hospitals tend to have different populations. Our university hospital, which has the lower number of patients but the higher percentage of ventilated patients, we do tend to take care of a sicker population, a lot of transplant patients, LVADs, things like that. So a lot of more probably complicating medical problems. We think that is what accounts for the higher percentage of folks in this hospital. They're on the ventilator versus the other. Our county hospital does have a bit of a younger, slightly healthier population. I'll tell you overall what we've seen in the intensive care units as we follow our data along has been the same thing that you see nationwide. Age is certainly a contributor to how people do over time. Also, diabetes and hypertension appear more common in the folks that we're hospitalizing for COVID, but we still have patients who are perfectly healthy, 20 and 40-year-olds on ventilators that don't have any of those things. So it does make the risk higher. It doesn't negate the risk if you are free of other health problems.
It should surprise no one because that's true with any disease, right? If you've already got other comorbid diseases, you don't do as well. If you're healthier, you tend to do better. but it's not a free pass. And I think that sometimes is what the illusion is
Right.
about the 20-year-olds. I'm healthy, I'm going to be fine.
Yeah.
And so I have a free pass. And the reality is, no, you don't.
No, it is a roll of the dice. And we've talked about our ages here. We have seen people in their 20s. Right now we have 2 pediatric patients, older in their teens, but pediatric patients here. Anecdotally, when I was on the floors last week, I had 2 different people in their 40s. One was really well-controlled HIV and otherwise healthy, and he was requiring oxygen. The other had no medical problems and was up in the ICU because he needed higher amounts of oxygen. But then again, I had somebody in their 60s who just required a low amount of oxygen, who didn't need any therapy. So you run the gambit, but you really, it is a roll of the dice because we don't know how our body is going to react to this infection.
Okay, I remember this story. I got time for a quick story, and then we're going to wrap up today. My chemistry professor taught this story to us back at William Jewell College when I was a second-year organic chemistry student or something like that. And he, they said, let's go gather all the wisdom in the world, and we're going to compile it. And he sent all his wise men out, this king did, and the wise men came back, and they had volumes and volumes. And like, no, you're supposed to put it in one page. And they went back out there, and they gathered all the knowledge in the world. They got it into a book. Nope, that's still too much. They got it into a small book. Pretty soon they came back with one sentence on one page. There's no such thing as a free lunch. So if you're 20 and you think you got a free lunch around COVID, forget it. Last question.
This is an innocuous one that there are several people on the thread that would like you to address. There is news reports, not saying where they're reported, that hospitals are elevating their numbers so that they can cash in on the government money.
Oh, gosh.
Yes. Wow.
Okay, I'm just going to tell you it's not true. Sonia, you guys cashing in on big government dollars?
I haven't seen it.
We report honest numbers every single day.
Yeah.
There's no inflating of numbers, and we get into big trouble when we do stuff like that. Then that's called Medicare fraud.
Right.
And you go to jail for Medicare fraud, and the damages are triple or quadruple whatever your fraud was. So if you defrauded the government $10 million, you got to pay them back $40 or $50 million. And the leaders go to jail. So I will just tell you, there is absolutely no way that we are putting out false information because A, we wouldn't do that. That would violate the public trust. B, we would get into a lot of trouble. And C, I don't look very good in orange, okay? And I really don't look good in orange stripes.
I don't want to go to jail.
No, I'm not doing that.
I mean, you don't want to defraud anybody, but you
No.
especially do not want to defraud the government because they will come after you.
Especially in the midst of a
Everything they
pandemic.
get. Right.
We don't have to tell fake information because it's real information. So I will just say to you, in almost to the point of being a little upset by a question like that, there is no dang way we are defrauding people by giving false information so we get more money. Plus, we lose a lot of money around this COVID stuff. There's just no way that we're going to do stuff like that to get more government dollars. And frankly, there's not a lot of government dollars out there right now. Most of it is ended. And the last 5 rounds of funding have gone to different places than KU, and I'll tell you that.
And that has to be paid back. It's not free money.
That's the other part. When you borrow a lot of it, 2/3 of the dollars we got were advance payments from Medicare. Beginning August, we don't get paid by Medicare until we pay it all back. So why would we want excess dollars? Well, it wouldn't help us. It was just more money to pay back. Hey, Sonia, final thoughts today, there, Dr. Bartolome. And by the way, what a pleasure to have you on our program. You may have to come back now.
Oh, love to. Thanks for having me. It was lovely to be on. As I said, I think it's a great program. Watch it all the time. My final thoughts would be the same ones that we keep repeating, but the risk of transmitting COVID-19 and getting COVID-19 isn't one you take on for yourself. It's the one you take on for your community. And even if I and my teenage kids can go out and our risk of getting very ill might be low, I am transmitting that risk onto a more vulnerable population. And so this is an inconvenience for a period of time to stay home and not do some of the things we want to do, but it's how we take care of the most vulnerable.
All right, and you tell Ivan, and of course yourself, ready to go fishing again. We got to make sure we all stay healthy so we can do that.
Yeah. Well, as we're going into the weekend, it looks like it'll be a nice weekend. We encourage and really implore everyone, do not meet in large groups. Be outside if you can. Physical and social distance, 6 feet is okay, 8 to 10 feet is better. We had patients on yesterday on a program, and they just implored everybody to listen to their stories because it's real patients, it's not just numbers on a page. use the mask. All parties use the mask, and of course, hand hygiene.
So, yes. Hey, next week we're back on the program. It's really a week about education. Can you send your kids safely back to school? What about colleges? How we reopen? What does that look like? What is it going to mean? And so we'll have a lot of folks lined up for next week who are going to speak to us about that, and some real experts in the fields of education. So that'll be fun. So be with us if you can. A couple of photos to end with. Thank you to Erin and her clan from somewhere in the high country. They're outdoors and they're wearing their masks. Great job. We head in the weekend. A couple examples we want to show you of social distancing. Matthew and his son just finished an 8-mile ride instead of going to the gym. He said, tandem keeps us safely in single file. And from Laura, who made their own street pickleball court in their neighborhood. Well done. Kind of stay out of the traffic, of course, and if you're in the street playing pickleball, but a great example of distancing. You know, God, these are hard times, and it really is a long and winding road. Where is it going to take us? Where are we going to go? Where are we going to end up? You know, the truth is, the answer isn't unknown to us. We actually know the answer. And we know how best to get there. You can drive that road, and you can be safe on that road. But just as you don't pass or a double yellow line around a blind curve, be safe on the road. Wear a mask. Keep your distance. Wash your hands. Do the right thing. The next right thing. That's what we do to stay safe. It's not some big study. It's not some huge science. It's not some big political thing. Just do the next right thing. Then we stay safe. And that long and winding road straightens out a little bit. We get there faster. We get there together. We'll see you next week. In the meantime, remember, there's still no place like home.